The order, meeting of the Managed Care Committee, pursuant to the Illinois Open Meetings Act. Meetings held remotely like this one will require a roll call vote for all actions and items. We have just one item, which is minutes at the end of our meeting. Secretary, will you call the roll, please?
Director Curry?
Present.
Director Harrington?
Present.
Director Ketting?
Present.
Chair Munar?
Present.
And for the record, those directors also attending, Director Guggenheim?
Present.
You have a quorum.
Fantastic. All right. Do we, Debbie, do we have any testimony?
We did not receive any.
Great. Why don't we turn it over to Interim CEO of the Health Plan, Aaron Galiner, for his report.
Thank you, Chair Munar. And Deb, I think I've taken control of the deck, hopefully.
You have, and if you want to use the up and down arrows as a Adobe Acrobat, there you go.
Great, thank you. All right, so we'll start with our usual metrics today, starting with membership, which through July 5th was at 435,000, just shy of 436,000. In terms of overall market share, this data from the state is through May. We're continuing to see our market share increase and is up to 32.6%. This chart shows our overall membership increase compared to the Cook County Medicaid market. Again, this data is through May, which is what's published from the state. So you can see over the past 12 months, our county care enrollment is up about 8% compared to the overall market's enrollment increase of about 4%. This graph shows our membership as compared to budget. So red bars are actual membership, blue bars what we had budgeted for, assuming redetermination, and that redetermination would start at the beginning of this year, but it continues to be delayed as the public health emergency continues to be extended. One note I want to make is if you look at the red bars from June to July, you can see this is one of the first months where we've had our membership essentially be flat or a slight decrease even, and that's because of a policy change that the state made between June and July. They reverted their choice period. They had suspended that at the beginning of the pandemic.
That would be awesome. Yep. Yeah, I think Allegra panicked a little bit when she said, Kim wants us to train. And I was like,
please mute. Thank you.
So the state re-implemented a 30-day period that members have to choose a health plan before they're auto-assigned. At the beginning of the pandemic, the state had suspended that 30-day period. So basically, for all of the MCOs, there's a 30-day sort of delay that's happening right now in members coming in for auto-assignment during this period, which is why you see this slight impact here on membership in that month. Looking forward to August, we're also expecting a one-time impact to membership in August. The state has another item that they are catching up on, which is members that are being terminated from Medicaid coverage due to having some other third-party coverage. The state's had a backlog in getting caught up on those. So we're seeing a somewhat significant impact so far in our August data related to that of about 6,000 members that we're seeing impacted by that catch up that the state is doing. So two one-time items that are happening right now that we expect will have some noise in our membership in July and August. But beyond that, we expect the underlying trends to remain pretty consistent as long as the public health emergency continues to be extended. In terms of our operation metrics, these are continuing to perform within SLA and no real major variances to report there. In terms of inpatient utilization, we're continuing to see year over year that Director Curry, did you have a question?
Yeah, actually, I should have asked earlier on an earlier slide, and I know there's some detail that will be discussed later on relative to domestic spend. But I noticed that despite the significant increase in membership, say about 60,000 above where we are, and I look back historically, domestic spend itself hasn't changed much to capture within our ambulatory care network. So I wanted to hear some discussion around that. And I can wait until you get into the domestic spend and some of the initiatives and things that are going on. But I had hoped to see maybe some increase in that percentage given this additional influx of membership. But it doesn't appear on surface that the bar has moved much. And I don't want to conflate two separate items that may or may not be related. So I just want to give you a heads up. And if we could talk about that later on when you get into the strategies for improving domestic spend.
Yeah, happy to address that.
Thank you.
So this slide shows inpatient utilization per 1,000. The red bars are prior period, the blue bars are current activity, and then the light blue shading is projected activity. So you can see year over year, we're continuing to see lower inpatient utilization. I will note that March, April, and May, we're projecting a little higher than we have been from November through February. And part of that's just that we saw some increase in specialty visits happening towards the end of last year and early this year, which we think is starting to flow through on the inpatient side. We saw sort of a increase, and then those leveled off in terms of specialty visits. So we're sort of monitoring the inpatient side to see if we see a similar trend there. In terms of vaccination rates, these have remained relatively steady recently at right around 56% with at least one dose of vaccine, and right around 50% that are fully vaccinated.
Does this include vaccinations for children where relevant?
Thank you for that question, Director. So right now, this data includes vaccinations for children ages 5 and up. The next iteration that you'll see of this will include the recent expansion of the age group.
No, that's good. So that probably suggests we're seeing a little more increase in our actual vaccination effectiveness than would otherwise be the case, because as we bring those on, there are a lot of kids in our network.
Yeah.
Director Curry has a question, and I'll have a follow-up.
Yeah, Aaron, I think this was asked for a few. Do you have a sense where we compare with other large public MCOs relative to the vaccination percentage of their membership in other urban settings? Do we have any line of sight to that?
Yeah, we haven't seen recent data published on that. Maybe about 6 to 8 months ago, there was a comparison of data across MCOs that were published, and we were the highest rate among the Illinois MCOs at that point in time. We suspect that's relatively the same, but we just haven't seen any recent data that's been published around it.
And thank you. My question is, are we tracking, are we also tracking for people that are eligible for a booster?
Yes, we are, and we can certainly share that data. But part of our outreach and follow up with members is both around the initial vaccine as well as the follow up boosters as they qualify.
Awesome. Is that in the fully vaccinated, or is that not here? I'm just curious.
That is not here. We could share some of that information as well. Fully vaccinated here is just representing the initial 2 doses.
Yeah, that Heather might just change to 2 doses to eliminate confusion, because the definition of fully vaccinated keeps changing.
Yep. In terms of claims payments, we're continuing to see a consistent trend of around right around the 30-day mark. Again, here's data broken down by aging categories. You can see over 30, 60, and 90 days continues to be pretty minimal in terms of over 30 days, and particularly the 30 to 60-day category, which is where a lot of the recent activity has been driving down that aging category to really stay at the 30-day mark. So in response to a few questions that I've received recently around utilization of members at CCH, I did want to provide a couple slides that talk about some of the current initiatives that are underway. And Director Curry, to circle back to your question at this point. Yeah, so certainly we've seen an increase in membership, and we've seen sort of a proportional increase in members that are impaneled to Cook County Health clinics. And so we would also expect, typically to see more of that flow through then downstream as those members come into care with CCH. So there is some nuance there in terms of, there's some yearly change in terms of the fee schedule rates and some other things that you have to account for in terms of the total dollars that are flowing through. But generally, I agree with your overall point, which is that we haven't seen the proportional increase in utilization at CCH as we would expect based on the volume of members that are now impaneled there. And so part of the response to that is that we've launched a work group with CCH specifically around this area and really around ensuring that we get activity from our members, that we get them to a PCP and engaged with the PCP, and then around specialty access and how we can better work with not just our internal clinics and the follow-up specialty care that may be needed, but also moving towards being more open to external partners and referring providers externally, such as our FQHC partners. So there's sort of 5 main areas that these initiatives have been focused around, and those are displayed here on the screen. And in the next slide, I'll talk in a little more detail about these. So on PCP engagement, we're targeting to increase the number of impaneled county care members that are seen by a PCP. So our data is showing that about half of the impaneled members have had a PCP visit over the past 12 months. And that may be for a number of reasons. Of course, the pandemic is still impacting some of that utilization, but we really want to see that number up closer to 80%. So working with CCH, we have been doing targeted outreach to members, and there's been some prioritization of members based on condition, based on gaps in care, based on length of time that they haven't been connected with the PCP for outreach and scheduling. And so we're just sort of at the initial stages of this, but we've been encouraged by some of the initial results we've seen in terms of members that have been connected from some of the initial rounds of outreach and then scheduled for an appointment. So here over the next month or two, we should have a lot better data about how many of those have completed an appointment, and then how sort of the next rounds of outreach are happening. We are also targeting specialty access, as I mentioned. So really both in 2 ways. One in terms of our internal CCH process for our internal PCPs and the streamlining the ability for them to refer over to our own specialist and get that sort of access for county care members, and ensuring that there's no issues that may come up due to length of time to get an appointment, for example, that may trigger an external referral to somewhere outside of the system for that specialty appointment. So ensuring that we've got good processes in place to ensure that availability is there and that there's controls for those external referrals. And then beyond that, really working with partners that we have in our network to try to help drive more volume in terms of specialty referrals and access to CCH. So that really starts with being able to have good availability, a streamlined process for the provider to schedule those appointments, but also our process and ability to get information back to those PCPs after the visit, including test results and any other information from the visit. So historically, external providers haven't had access to our EMR or have other barriers have happened that hasn't allowed that information to flow back in a really provider-friendly way. And so much of the efforts now are to really streamline that process to make that easier on the provider. Director Story, did you have a question?
Yes, thank you, Eric. Piggybacking on an expressed concern that Commissioner Daly has about county care. You've heard him ask questions over and over again about redetermination and what happens next, for county care. And the two issues that you raised this afternoon about the leveling off and the resetting that some of the folks that the folks in Springfield have done. Would it be, or have you thought about, or is this in, with respect to domestic spend and the other concerns that have been expressed by folks like, Commissioner Dillon, would it be worthwhile to sort of add to this navigators or outreach folks to try to ensure or stabilize or maybe slow down any potential decrease in the number of patients who might consider other options in the market other than county care?
Yeah, certainly. So I think as the market itself becomes basically more consolidated with redetermination, right? The ability to grow market share during that period becomes even more important. And then I think on top of that, in particular, the redetermination losses with county care members that are also impaneled to CCH are really critical for us because they're not just county care members, but they're also one of the big impacts that we see at CCH in terms of the reimbursement there. So I think targeted outreach for those populations is really critical.
So would you necessarily need additional resources, or is that something that we should be advocating in the budget for 23 in just preparation? I surmise that it's probably not just, what you're doing here, and I applaud your efforts, and that is something that I'm sure Commissioner Daly would love to hear more about. This is very, very important to him and others like myself. So any support that we could lend, I think, you should ask for.
Yeah, I appreciate that. I think on the navigation and outreach component specifically, I think that's a review that I'll need to do with CCH, since a lot of the application assistant work has to be done by CCH and can't be done by the plan per the state's regulations. But certainly I think that needs some evaluation, especially given the surge we're expecting. So there's going to be this large one-time influx once the public health emergency ends. So how we resource that and ensuring we've got the right resources there, I do agree is critical.
Thank you. That's all I had.
Moving down to the urgent care clinics. So we've been reviewing in partnership with the ambulatory clinics, basically an option for expanded hours, potentially at 2 of the ACHN clinics, to really try to open up more convenient access for members. And we've leveraged our county care ER utilization data to look at where we're seeing a lot of that utilization and after hours ER utilization, and geographic areas that are close by some of our clinics to look at where some of those opportunities are. And then finally, pharmacy at CCH is another area where there's a lot of opportunity for us in terms of prescriptions that are written by our internal Cook County health physicians. To the extent that those go to Cook County health pharmacies, including the mail order pharmacy, which is a great option for our members in terms of convenience. That is both good for the health system, and it also can be done leveraging the 340B pricing. So there's dual benefits to that. So now I'm going to transition into several of our sort of strategic domains and talk about different initiatives that are underway across each of these. And as we continue to move forward with implementation of the strategic plan that the board approved, one of the things that I'm hoping to do through these committee meetings is try to demonstrate the initiatives we have under each of those domains, as well as what our objectives and key results are for each of those. So this is a format you'll see more and more of going forward. But starting in our fiscal resilience area, I wanted to provide an update on what we call our medical cost action plan process, which you've seen before, but is just our process really for how we manage and provide project management to specific cost and revenue initiatives across the plan. So we assign owners to each of the initiatives in each of the areas, and then there's an ongoing process of monitoring the progress on those in regular meetings with our leadership team to ensure that we're progressing on each of these items. So to give you a sense of where areas of focus are in 2022 right now, really across pharmacy, finance, medical management, network, and compliance. So in pharmacy, we're targeting about $3 to $5 million of savings this year related to 340B opportunities, which I just mentioned before, which also overlaps with some of our initiatives in terms of utilization at CCH. On the finance side, I'll highlight a couple areas. We're continuing to evaluate our IGT with HFS, which you may recall we made a change to last year, but there continues to be some opportunity there. We're also continuing our efforts to enroll individuals into SSI or SSDI, which is both great for our members as it gives them additional income source, but it also moves them to a higher rate cell with the state, so it increases the revenue that we receive. We're also working on risk adjustment, and we've gone through a number of RFPs this year, which we've talked with you about around the MHN ACO contract, and we also have the TPA and PBM RFPs in process. On the medical management side, we are in the process of standing up work around focused around end-stage renal disease and chronic kidney disease, as well as really trying to work through the process and the technology we've got that's supporting our care.
We may have lost Aaron.
Right.
Oh, you cut out there for a minute there, for like 30 seconds, Aaron.
I'm sorry. Can you guys hear me okay now?
Yes.
Yeah, this is Director Harrington. I know there's been a significant increase in end-stage renal disease. And there are things that can identify people that are at risk for kidney failure and going into dialysis. And how aggressive are we in terms of identifying those patients and putting them into some kind of treatment plan to reduce the likelihood that their kidneys will fail?
Yeah, so we actually went through a process to RFP to have a vendor support us in this area over the past year. So we're in the process of implementing with a vendor to do exactly that, to have targeted intervention, not just once members get to the ESRD stage, but also as their kidney disease is progressing. And really trying to avoid the sort of crash into dialysis that a lot of patients experience. And that's also, extremely costly from a plan perspective. So, and there's also opportunities once a member gets to a certain point with ESRD that they're able to move on to Medicare if they so choose. So we also want to ensure that members have those options available to them as well.
Yeah, and the major contributing factor is diabetes and high blood pressure, uncontrolled diabetes and high blood pressure. So the more emphasis we can put on getting patients to do a better job of managing their blood pressure and their diabetes, less likely we'll see the numbers on the end in terms of end-stage renal disease.
And then
I think that's really important, and it really ties in with the things that Israel's talked about in the Change Institute about how we use our information resources to focus in on those, because it's a huge quality of life issue, and we just really need to focus on catching these problems as far upstream as we can.
And then the final two areas I'll mention are both network and compliance. Our compliance team really does a great job with the FWA work, with our special investigation unit to look for any unusual utilization patterns and those sorts of things to ensure that we're on top of any FWA and potential issues there. Director Terminar?
Yeah, thank you. Just a question about that. I was surprised that the yield could be as high as 4 to 6 million in the compliance space. I don't know. That just seemed like a high yield for that area. Do we know? Are there particular initiatives that are being explored?
Yeah, so there's a couple comments on that. One, there is a bit of a catch up that's occurring right now. There was some state restrictions during the pandemic in terms of how health plans could proceed with recouping funds from providers. So there's some catch up that's happening there. But from there's sort of ongoing efforts in terms of data mining that happens, and then more specific investigations from the SIU team. But really, it's in terms of specific initiatives, those sort of evolve based on both information that's coming out in the market. The MCOs and the SIU teams all meet regularly to share unusual utilization or other patterns they might be seeing, as well as, of course, new guidance that comes out from other sources, such as federal OIG and other areas. So I think this is maybe a little higher than what we would typically expect, but I wouldn't say dramatically so. I think for the past few years, we've seen somewhere between the 3 to 5 million range of actuals.
Okay, thank you.
And then finally, I also wanted to talk regarding our fiscal resilience section on development of our health plan reserves. So As you may recall, the fiscal year 2022 budget included a target to set up initial reserves for the health plan of approximately 50 million. So that initial funding was completed earlier this year in partnership with the county and the county CFO office. We've been able to increase that up to 75 million, which we're really pleased about. In terms of overall longer term goals for this, industry standards and sort of actuarial analysis that we've worked with our actuaries to perform would suggest a plan of our size should have reserves somewhere between 125 to 150 million, which would be, if we were a fully licensed health plan under the Department of Insurance, what would typically be required. So over time, this is where we would like to get total reserves to be at to ensure long-term stability. These reserve funds are held in a dedicated county care bank account that the county established in the beginning of fiscal year 2021. Which has also been beneficial for us in terms of increasing the timeliness of the claim payment process as well.
A great start, Aaron. It's impressive. Great start.
Thank you. All right, strategic domain that I want to talk about next is growth and retention. The main area I want to focus on is redetermination, which of course is the big topic as we continue to track guidance with the public health emergency. So you've seen some of this information before, but I just want to reiterate it. So right now, the public health emergency is scheduled to end at the end of October. We have been told that CMS will provide guidance to states at least 60 days prior to them ending the public health emergency. So the deadline for any indication of that, if it's going to end in October, would be August 15th. So we'll be watching that closely as that date comes up. If there are no further public health emergency extensions, and it does end on October 15th, states have 60 days to begin the redetermination process. So we would expect to start to see impacts no later than December of 2022 if the public health emergency does end in October. And then once that begins, the states indicated that they're expecting basically equal sort of installments each month will flow through of members up for redetermination. So we would expect about 1/12 of the membership each month would be going through the process.
Thank you for that information. The redetermination, or I guess a couple questions, has been, this is probably the second or third extension that they've authorized. I guess, do we know what criteria they're using for, or really the question is, how likely is it that this will, the redetermination will proceed at the end of this calendar year? Or is there a chance that it might get extended again?
Yeah, I definitely think there's a chance that this may get extended again, especially looking at the current surge that's occurring. And again, the CMS is committed to the 60-day time frame. So it's likely we're going to continue to be in the current surge as we hit that August 15th date. But beyond that, there's not a clear sort of indication out there. But I will say we have seen increased activity from CMS in terms of guidance that they're giving to states around the end of this PHE. So there does seem to be an increase in activity, which at least suggests they're looking towards ending this at some point.
Okay, thank you.
In terms of activities that we're undertaking right now, still most of this effort continues to focus on ensuring that members have the right information with the state so they get the right forms when the process does start. So a lot of activities continuing around outreaching to members through text, email, website, care management staff, to let members know that this is coming and ensure that they've got the right information updated with the state. We've also got real-time three-way calling that's happening with the HFS hotline to help members update their information.
Aaron, Director Curry, with respect to these initiatives, I assume they've been in place for a while. Is that correct? Or are these new engagements going forward?
Yeah, so they have been in place for a while. Different pieces of this have been brought in over time. So not all of these started at the exact same time, but I'd say we've really sort of launched a lot of these efforts in earnest, specific to the end of the public health emergency, probably over the past 90 to 120 days.
And are these broad-based initiatives that are going out to the entirety of our membership, or just selected, identified groups or tranches? I just want to get a sense for how far and how deep we're going with these to get the most effective results.
Yeah, it's both. So there's some broad-based strategies that are across the entire population, including things like our social media campaigns, and then there's some more specific outreach that's dedicated to, for example, we may know when a member doesn't have an updated mailing address if we send out something and we get return mail from that member, right? So when that happens, we're flagging those members for specific outreach and trying to see what other touch points we may have if that member's already connected with a care coordinator, for example, and if there's different avenues we can leverage then for that specific outreach.
So aspirational goal, I think, is what we want to set that.
That's fine. That's fine, as long as we understand that
I'm glad that
retention is what's called premium level 2 children. These are children in the state's program who may have had some
level 2 children. Could you just expound on that? Just a little bit more definition.
Yeah, so this is a subset of the children that were basically under Guggenheim.
Yes, I've sort of triggered a thought when you talked about using the public school connection as a possible sort of outreach strategy. Have you thought of using the Catholic school network too?
We would be very interested in 2 to 2.5 years now to increase these numbers, and so we're happy to show that during state fiscal year 2022, we're now exceeding that target at about approximately 38 million to the target of about 28 million. And really the action plan around this is focused on four main strategies through this, but we've been really doing a focused initiative across our county care team that has been both employee driven, the strategic initiatives we're working on. So we're really excited about this work and think this will pay a lot of dividends downstream. And with that, I'm happy to answer any questions.
I will motion for approval of the minutes. If there's a second.
So moved.
Second.
Debbie, you can take the roll call, please.
Roll call vote on the motion to accept the minutes. Director Curry, aye or nay?
Aye.
Director Harrington?
Aye.
Director Keding?
Aye.
And Chair Munar?